Urology Registrar, currently working at Worcester Acute Hospital NHS Trust in Worcestershire. And I'm very pleased to be presenting in the IUCS 2025. So I'll be talking about the predictors of cancer detection of local anaesthetic transperineal prostate biopsies. So in our trust, in accordance with NICE guidelines, men with suspected prostate cancer, they undergo pre-biopsy MRI to guide targeted sampling. In our trust, we do targeted sampling as well as systematic biopsies. So LATP, it has become the preferred first-line approach because it offers lower infection risks and improved access to anterior lesions compared to the transrectal route, and a recent study has been published to prove those findings. So despite its increase in use, we still don't have much evidence on predictors of cancer detection in LATP. So that's why we look into PSA levels, the PI-RADS scores, and the histology as to predictors of their cancer detection. And the other thing that we do is we look into the follow-up strategies for patients with benign findings, and whether on repeat biopsy they do come back with cancer. So looking into our methods, the study design, so we retrospectively reviewed 616 men that underwent prostate biopsies under local anaesthetic transperineal route in Worcester Acute NHS Trust between November 2023 and April 2024. We registered it as a clinical audit in our audit department and received ethical approval from that. There was no deviation from the standard care that we used. So the biopsy technique that we use is using the precision point freehand transperineal access system. We also use local anaesthetic, so to the skin, lidocaine and adrenaline, as well as the periprostatic nerve block. And we also have a tailored antibiotic prophylaxis regime in our hospital. We don't routinely give everybody pre-procedure antibiotics. However, a subset of patients, which includes patients that are immunocompromised, including type 2 or diabetic patients, as well as patients who've had previous sort of mechanical heart valves, previous biopsies as well, and post-void residual of more than 150 mils. So there are a specific subset. So that leads to 12% of our patients having pre-procedure antibiotics. And those antibiotics are gentamicin, a stat dose of 160 milligrams intravenously, and then oral ciprofloxacin. Then 13% of patients also have post-procedure antibiotics. And then we look at the sampling protocol. So in our trust, as I've previously mentioned, we do take systematic and targeted cores. The targeted cores are from the MRI findings, so PI-RADS 3 or more lesions. That leaves us with an average of 23 cores per patient that we do take. We report the histology using ISUP grade group system. We looked into the benign cases, but we excluded prostatitis, ASAP, and high-grade PIN in that subset. So the follow-up analysis, we looked into the benign cases. We classed them as patients that were either discharged, monitored, or had a repeat biopsy. Some of them were unclear. That was a really small subset of patients that either self-discharged or were transferred to different centres, and they moved areas. And then we recorded the outcomes of the repeat biopsies to see what happened with those. So looking at the results, the key finding is we had 66.8% of patients that were positive for cancer after having their LATP biopsies. So that's 412 out of 616. If we looked at just the PSA, the mean PSA was significantly higher in cancer cases, as you can see in that bar chart, 17.8 versus 6.3 in benign cases, which showed that PSA demonstrated a strong predictive value for malignancy, which has been sort of highly recorded. Now, if you look at that and the PI-RADS on the MRI correlation in the chart, you can see that actually PI-RADS 5, 84% of patients did have cancer following the biopsies. In PI-RADS 4, it's 76%, and PI-RADS 3, it's 51%. So it demonstrates that there's a strong, correlation with cancer detection rates. However, it also shows that we need to look at risk stratification and clinical decision making, especially for patients who have PI-RADS 3 lesions, when we should rebiopsy and whether we even should. That's why we looked in detail into the management of the benign cases. So that was 143 out of the 616 cases. And in that cohort, 46.2% were discharged, 42% monitored, and 11.8% underwent further investigation. And some of them, so 16 out of those cases, underwent repeat biopsies. 10 of those 16, so the vast majority, remained benign. However, 37.5% of patients did get diagnosed with cancer on repeat biopsy. 2 of them, so 12.5% of these, actually had clinically significant prostate cancer, so Gleason grade 2 or more. Now, both of those cases that did have clinically significant prostate cancer had PI-RADS 5 lesion as well as a PSA of over 10. So they had strong reason and indication as to why to repeat that biopsy. Also a good note is the safety profile. So of these patients that had a repeat biopsy, no cases of sepsis or major complications were recorded throughout this cohort. However, we did have 3 cases of urosepsis overall. So out of the 616 patients, 3 patients did have urosepsis. None of those cases received pre or post-procedure antibiotics because they didn't make the criteria. They didn't have the criteria for our trust to give them those antibiotics. So, in conclusion, the LATP biopsy does demonstrate an excellent safety profile with a high cancer detection rate of 66.8%. Now we can use predictive value factors such as the PSA level and the PI-RADS score to strongly predict the probability of them having a malignancy. And the PI-RADS 3 lesion, it still remains a diagnostic challenge. Therefore, we should have a robust sort of follow-up strategy. So, in our repeat biopsies, 12.5% of those patients had clinically significant prostate cancer. So that's why we should use, risk-adapted follow-up pathway approaches post-LATP biopsy. And with it bearing in mind the strong correlation between PSA and PI-RADS scores as well. So thank you very much for listening to my presentation.